Good morning, everyone. So welcome to Connecticut Partners for Health's 6th annual Better Health Conference. Just out of curiosity, how many people have been to all 6 conferences so far? I know there are a few of us. I'm not sure we thought we would get to 6 years, but we're really glad we did. I'm Steve Ruth from SMC Partners and representing eHealth Connecticut, and I'm the chair of Connecticut Partners for Health. So about 7 years ago, our friends at Qualidigm had this brilliant idea, right, Ann? To bring together healthcare stakeholders from around the state to address what was becoming an evolving and at times confusing healthcare environment. Ann Elwell and Tom Meehan, who is here today as well, and they'll be up at the stage at some point, they convened a monthly meeting where we discussed any number of topics relevant to the lives of healthcare consumers and to find ways to bridge the gaps, the widening gaps in understanding and services. This resulted in our first conference 6 years ago at this venue. To our surprise, we attracted about 500 people to that first conference, a multitude of vendors and sponsors and many incredible speakers. Our group was so encouraged that we have continued this tradition that has led us to where we are today. So actually, where are we today? A few months ago, we began discussions with 2 organizations who have worked closely with Connecticut Partners for Health and have contributed to our success. ProHealth's Connecticut Center for Primary Care and the Connecticut Choosing Wisely Collaborative were those 2 organizations. Our discussions are ongoing. A more formal collaboration is in the works, and today, this conference is a result of this emerging partnership. I want to thank Tom Meehan from CCPC and Laura Morris, who represents Choosing Wisely from Connecticut's Office of Health Strategy, for their leadership on this. Well, it's through this collaboration and our ongoing relationship and ongoing partnership with New England chapter of HIMSS as well, that we were able to once again draw leading healthcare experts who today will share valuable information in support of patient-centered care. For those of you who are not familiar with HIMSS, folks, our board is sitting over there at the table, they are the International Trade Organization for Health Information and Technology. And a special thank you to my board members, and especially to Craig Schneider, who is with Ann Elwell, has really led our program committee for a number of years, almost all of the years that we've been here. The leadership of the chapter has really been helpful in both getting people here and sponsoring the conference. So visit the table if you're interested in HIMSS. They're out there on the floor. I also want to take some time to thank the team at Qualidigm, who they really are the folks who turned this conference into a reality. Qualidigm is a fiduciary organization for Connecticut Partners. It underwrites and takes the risk on the conference and dedicates its team, consisting of its CEO, Tim Elwell, Nancy Kelly, Dory Horn, Kate Slumkowski, and Morgan Gargiulo, among others. Right, Morgan? You may have also noticed, well, you will notice because I'm not sure they're set up yet, the research posters that are located near the exhibit area. And thank you, Tom and CCPC, as this has been a hallmark of their annual conference over the years. I encourage you to spend some time in the poster gallery area to meet the students, residents, and fellows, and learn about their innovative research projects related to primary care. So we've got an exciting program planned for you today. We'll be highlighting a variety of meaningful topics that influence how care is delivered to patients. We have an extraordinary lineup of presenters who will be speaking on a variety of topics related to social determinants of health, primary care, health equity, and health information and technology. Additionally, this year we will be handing out a few awards. One for the Connecticut Partners for Health Distinguished Service Award, an award we initiated last year, and Elwell was the recipient of that award. And CCPC has a number of primary care leadership awards as well. You may also notice some camera activity. We're live streaming today. It's the first time that we're doing this. Today's program to several attendees, partners, and friends outside of Connecticut. So welcome to all of you out there. Why don't you turn the cameras back there? We could all wave to our friends out there. Thank you to our camera person as well, too. So wave to people in TV land. And hope you all sort of enjoy the conference as well, too. I know we've picked, we think, some sort of special topics for you to be able to watch. So throughout the day, we'll have several breaks in between the sessions. I encourage you to really to meet with the sponsors. We've got a special, one of the feedback that we really have had about this conference is that people sort of love interacting with the vendors out there. It's very social, very collaborative, and a great place to network. So make sure you get out there, meet the vendors. I especially want to sort of want to give Cigna sort of a shout out sort of again this year. They've stood up again to be our premier sponsor, and you're going to hear a few words from their CEO, Scott Johnson, at lunch. They also have a pretty cool thing going on their booth. They've got some roulette wheel and some game going on, so make sure you visit them as well. And if you're active on social media, please use that hashtag BetterHealthConf19 and share what you're learning, seeing, and who you're meeting at sort of today's conference. We're going to sort of try to share some of that stuff at lunch. I'll do the first one over here. I'll post it right over there. Everybody wave. Oh, I forgot to smile, but that's all right. We'll try to sort of get all that stuff at lunch. But really, those tweeters in the audience, please sort of feel free to do that. Just a couple of housekeeping items, and I'll get out of the way. You should have received a conference brochure when you picked up your badge today. Inside that brochure is the evaluation. That evaluation has been extremely special to us. We actually, we take a look at that sort of throughout the year. We actually go out and reach out to speakers to meet some of the needs that you all sort of have identified. So please complete that evaluation, drop it in one of the blue bins near the registration area. We value your feedback. It really does help us determine how we can improve the conference each year. There are more brochures up at the registration desk if you haven't gotten that. And we hope you're going to be able to stay for the cocktail hour. Why would you miss that? It begins at 4:45 in the exhibit area after our closing keynote with Kevin Carr and the Primary Care Awards presented by Tom Meehan. We're going to do that at the end of the conference. We'll have drinks, plenty of great hors d'oeuvres, and it is a nice way to end the day, continue networking. There is a ticket in your name badge. Should be in the back there, so you do get a free drink on us. One last housekeeping item. I think people have already asked questions about the parking passes. We have them for you on your way out. Be sure to pick it up. Your parking will be covered sort of with your registration. And what I'm going to do now is really get out of the way, and I'd like to give a special welcome sort of to Vicki Veltri, the Executive Director of Connecticut's Office of Health Strategy, who has been a loyal supporter of the Connecticut Partners for Health really from the beginning. She was on our board before she got way too busy sort of to continue to work on that. She's someone I consider a good friend and a really good supporter of the organization. She's done incredible things for the state. I'm not going to read her bio. She told me not to. With her role in overseeing the vision of healthcare in Connecticut, we're honored to have her sort of help sort of MC today. So without further ado, Vicki, it's all yours.
Okay, what am I, 6 feet tall around here? Good morning, everybody. Okay, come on. Good morning, everybody. Let's go. All right, we're here at the Better Health Conference again this year, 2019. This has been a fantastic conference over the years. We've had great speakers. We got a great program for you here today. We got people from all worlds of healthcare. As you know, healthcare is really complex. Steve was just talking about this. Healthcare is in some ways getting more and more complex. That's why we've got speakers here to help talk about how do we try to make healthcare less complex? How do we work with technology, which is evolving very rapidly? How do we simplify? We'd like to simplify health insurance. How do we work together to make sure that we're accounting for things that affect health but are not really considered in our sort of overall thinking, healthcare? And what I like to tell everybody, everything is health. Everything you do every day affects your health, your housing, your employment, your education level. Things like that all affect your health. We need to talk about that more. So, I want you guys to be energetic. I want you to enjoy this conference. Please participate. We really try to make this an interactive day. We have moderated panels so people can participate, ask any questions you want. I know a lot of you may have been at the legislative session, I don't know, but our legislative session, ended last night. So some of us are here and some of us are, like the Elton John song, still standing. You know, I'm still standing. So you guys need to get up and stand and be part of this conference today. We have a lot going on in healthcare in Connecticut. Connecticut is a good state when it comes to healthcare overall. If you look at the rankings, we're pretty good overall healthcare. But we have pockets of problems in this state. We have serious health disparities among populations in the state. We need to improve upon that. On the other hand, we have fantastic industry here. We're the home of major insurance companies. We're the home of major technology companies. So if anybody can do a great job improving healthcare, it should be the state of Connecticut. So with that, I'm going to use my technology as someone who wasn't born in the last 20 years. Technology isn't as simple for me, but I am going to try to introduce our keynote speaker. Now, before I do that though, I wanna say everybody here is gonna come back, right, at lunchtime and be really energetic and talk about things they've taken away from the morning sessions and how we're gonna improve healthcare. So I'm going to go on and introduce Dr. Reider. So Jacob Reider, where is he? Jacob Reider is a family physician who wants the world to be healthier. He's worked for decades to improve the health of communities through innovative use of technology and the promotion of benevolence in business. He currently serves as the CEO of the Alliance for Better Health, a New York DISRIP. I'm going to let him explain DISRIP because I'm sure a lot of people in the room don't know it. A New York DISRIP Care Transformation Initiative and an advisor for several private sector organizations focused on healthcare. He previously served as the Deputy National Coordinator for Health Information Technology at the United States Department of Health and Human Services. In his 3 years at HHS, he was responsible for policies and programs designed to improve health through the development and implementation of safer, more resilient, reliable, usable, and helpful health information technology. Jacob has more than 20 years experience in policy and health information technology with a special interest in user experience, something we can all relate to here today, clinical decision support, and information portability. He served as the CMIO of Allscripts, one of the nation's largest health IT developers, and was the Associate Dean for Biomedical Informatics at the Albany Medical College, where he continues to teach. Yay, upstate New York. He co-founded 4 successful health IT startup companies and has held directorships on boards on both nonprofits and private healthcare companies. Also holding leadership roles in the American Medical Informatics Association and the New York State Academy of Family Physicians. His interests include organizational leadership and culture, shared clinical decision-making, and evidence-based management of common outpatient conditions. So without further ado, let's welcome our keynote speaker.
Thank you. Thank you. I'm going to try not to use the microphone thingy there. Good morning, everybody. Thank you for having me. Lights are pretty bright. I think I can't see you if I don't have these on. So when I agreed to do this, I think that the team asked me, what's the title? What are you going to talk about? And I said this, what's the secret to a healthy community? And as I was preparing my talk, and those who have been involved know that I finished my slides about 2 a.m. last night. I searched the internet for the secret to a healthy community. So the first thing I found, you need the hip movement. It's kombucha. Obviously. So now we can all go home. So after I asked the internet, I decided I'd text some of my hospital colleagues, right? And they said, well, it's obviously a healthy hospital. That's what you need to have a healthy community, is a healthy hospital, right? And I promise not to tell you what DISRIP is, but I will. It's a 5-letter word. I shook my head. I don't know if anybody saw when I was challenged to describe it. DSRIP is Delivery System Reform Incentive Payment Program. It's a New York initiative that's an 1115 waiver, if you know what that is. Raise your hand if you're one of the 7 people in the room who knows what that is. Oh my God, double that, 14. So an 1115 waiver is something that CMS will give to a state to do something innovative with Medicaid dollars instead of fee-for-service. And so in our state, what we're doing is we're taking tens and 20s of millions of dollars and investing it in our communities, because what the state recognized is that when Medicaid members go to the hospital, half the time they could have received care elsewhere. Half the time. And so if we reduce that half to a quarter, we'll save about $2 billion a year in New York. And so New York said, feds, if you give us some money, say, I don't know, 10 billion over 5 years, we'll save you that much and more, and we'll creatively invest in our communities. So what Alliance for Better Health is one of these community programs where we're spending money to improve the health of our communities, and by extension, we're reducing fee-for-service volume for our hospitals. Now here's the irony. My board, 3 of my 5 board members are hospital CEOs. So it's my job to reduce their revenue. It doesn't make sense for a board to not want their company to succeed, but that's kind of the challenge that I have. So when I asked the hospital people what they thought was necessary, they said a hospital. When I asked the doctors and nurses, these are my friends, the doctors and nurses, what did they say? Doctors and nurses, of course. So the egocentrism, and I sort of poke fun at ourselves, but we all see the world from where we are, right? And what some famous Supreme Court judge, I think, said, where you sit depends on where you stand. And one of the key parts of how we've found success in our community is not to blame folks for being who they are. Our organization, in our early days, we wagged our finger at the hospitals. And we said, well, why don't you just put a stop sign at the emergency room and say, if you shouldn't be here, don't go here. And the hospital said, yeah, we'll figure that out. Just give a couple $1 million and we'll figure out how to keep people out of the hospital. How do you think that worked? It didn't work at all. So then I asked these 2 characters. And they were just laughing. I couldn't even get an answer out of them about how to make a community more healthy. That's the only politically risky slide of the day. Social care was the answer that we arrived at. And what do I mean by social care? So today's topics, now we're actually starting the talk instead of just ranting. Achieving better health, right? Isn't that what we want to get to? And in our community, it was all about finding the common goal. Because when I challenged the hospital CFOs and I said, you don't really want the community to be sicker, do you? Right? Because sicker equals more volume, volume equals revenue. But they couldn't look me in the eye and say, oh yes, I'd rather there be more people with the flu. So for example, this year we had a pretty light flu season. It doesn't mean it was completely light, but it was light. And one of the hospital CFOs actually said to me, do you know our ED volume is down 18% this year? Kind of blaming me. And I said, it's not my fault there was a light flu season. And do you think that's a bad thing? And then he realized what he was saying to me, right? So if we align on the common goal, achieving better health, and we get them to say that out loud, that's step 1. We know that physicians aren't the answer, and as a card-carrying member, I'll offer, we are important. We are not sufficient. And physicians have done a really good job at being egocentric, as we'll talk about in a little bit. Hospitals are not the answer. Change is difficult, and IT is an imperative component of success. I'm going to talk rather little about IT today, despite what you heard in my bio. Most of my background is in IT, but it's IT to solve problems. And we're now at the point in our world where we can actually presume the presence of IT and know that it's going to work with some confidence. So why are we doing this? I start with the social ethic, right? It's around the shared commitment to each other that we all want a healthier community. And here's the first of 2 book pitches for today. This is a brand new book. It's been out about 2 weeks, written by a dead guy. So Uwe Reinhardt, if you know of him, he was an extraordinary leader in the domain of health policy. So this book was just published from his writings in the last year or so of before he passed away. And it's a wonderful, if you've not read his work in the past, it's a wonderful review of some of his work of the previous 30, 40 years. And I strongly encourage it, and I don't have stock in Amazon.com. And what Uwe asked in 1997 is an important question that I like to pose to folks in our community. So I leverage this. This was a paper he wrote, which actually stirred up a lot of controversy, which then surprised him, right? The question was, as a matter of national policy, and to the extent that a nation's health system can make it possible, should the child of a poor American family have the same chance of avoiding preventable illness or being cured from a given illness as does the child of a rich American family? Doesn't that just make sense? And what was surprising is that some people didn't think it made sense. So I hope all of us in the room think it makes sense. It shouldn't be about where you were born or to whom you were born. Everybody should have an opportunity to be more healthy. So what is health? Well, let's ask the World Health Organization, because they should know. A state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. So notice the word social in there. This was 1946. And so, again, I'll malign physicians. We've just discovered this whole social determinants thing. Raise your hand if you're a social worker. Any social workers? A couple of you. My daughter just became a social worker, and she kind of rolled her eyes at me the other day. She said, "Dad, we're both social workers now. You've discovered what's really important." So we physicians, we've just figured this out. Holy crap. These other things really matter. And we can't do anything about them, or can we? So in 1946, the World Health Organization recognized that social well-being was an important part of health. And then we asked Uwe Reinhardt or others, what's equity? If we're seeking health equity, what's equity? Well, it's the quality of being equal or fair. So it's even, back to Uwe's question. Can poor kids count on being healthy just the same way that wealthy kids can be? And so then we think, well, what's care and what's health care? And so the way I think of health care, and sometimes I draw this like an umbrella, health care is at the top, social care, behavioral health, physical health. And for too long, we have conflated the two concepts, health care and physical care, or health and physical health. And we need to start remembering that the other two precede and are necessary for physical health. And if we ignore them, what's the word for waterfall in Spanish? Who's a Spanish speaker? Spanish speaker, come on. ¿Alguien puede hablar español aquí? No? Oh my. Cascade, cascada, is the word for waterfall. So we fall down the cascade if we don't address the social issues or the behavioral issues. People fall down the cascade. So you'll see this slide again, because we need to work upstream. That's one of the messages of our talk today, is that we need to work upstream. Because you see the little character on the kayak, he ain't going back up. It's really hard to go the other direction. So if we address people after they've fallen down, it's really hard. And that's the position that the hospitals and the doctors are often in. People have fallen down that cascade. And this is the doctor's view of the world. It's supposed to be confusing and you're not supposed to be able to follow it, right? This is how doctors kind of cob together these models for how it is that we're going to catch people when they land in our laps, but we're really not prepared to do something about it. This is the famous depiction of the percentage, and if you look in the middle, apparently the laser pointer isn't working today, so we're devoid of that. But if you look right in the middle, clinical care contributes 20% to health outcomes. The rest is more important. Air and water quality, housing transit, community safeties, family and social support, employment, education, sexual activity, alcohol and drug use, diet and exercise, tobacco use. All of these things are way more important than how good a doctor you have. And I'm not saying we should have crappy doctors, but it's only worth 20%. The other 80% is much more important. Sorry, Tim. Tim's job is to make sure we have quality doctors. He's giving me the evil eye over there. I've maligned physicians already too much, and this is the part where I'm supposed to malign physicians. So here are a couple physicians who wrote an article in Harvard Business Review in 2013, "The Strategy That Will Fix Healthcare. Providers must lead the way in making value the overarching goal." I disagree. I don't think it's something that we physicians can achieve because cascada. See, we've learned a word today. We medicalize. We physicians medicalize. I was at a conference yesterday and I was on a panel, and of course there were 3 doctors, I was one of them, and 1 PhD health policy researcher. And one of the doctors was talking about, we need better access to care. Is this what he was talking about? Is access to care a door to an 8x10 exam room where they will come to us? In our community, this is supposed to be really happy people in a Uber or Lyft or something. So we'll talk a little more about this in a bit, but in our community, one of the things that we decided to do was pay for Lyft or Uber for any Medicaid member for any reason. And it was a bet. And that's the wonderful thing about this 1115 waiver is that we can make bets. Because one of the things we kept hearing was, well, I went to the ER because. So I'll try and call on this rather sleepy audience. So audience participation time coming up. Why do you think people go to the emergency room? And I already gave you a hint from this slide. What's easier about going to the ER, especially if it's, I don't know, February in Hartford? Lady with the hand up. Bus line. They don't live on the bus line. They can't get to their appointment. So I was late for my doctor's appointment, so I went to the ER instead. Okay, keep going. This is fun. Open 24 hours a day, and I work the night shift. So I get off at 7 a.m. And my doctor's office isn't open then. Keep going. This is fun. One more. I don't have primary care. How about there's a 3-digit number I can call and someone will pick me up? And it's not 411. And this happens. And we slap them on the back of the wrist and say, you know, you shouldn't really have called 911 for your sore throat. But we roll our eyes, and I've been on those EMT transports. We roll our eyes. This happens every day. I don't know if it happens here. It certainly happens in Schenectady, New York, and Troy, New York. So we said, you know, why didn't they refill their prescriptions? No copay, not the bus line. It's all the things we were talking about just now. They couldn't get to CVS, and CVS doesn't deliver. So we'll pay for Lyft. We'll pay for Uber. Why didn't they make it to DSS to renew their coverage, their Medicaid? We'll pay for it. So we're making the bet that if I spend $10 to get someone somewhere, that might prevent an emergency department visit. And what's an emergency department visit cost, more or less? $2,000. Just pick a number. $2,000. So how many rides do I have to pay for that had nothing to do with prevention until I get to $2,000? It's a lot. So these are the kind of bets we can make, and that's one of the bets that we're making. We're going to them, and this will be another theme of our day. So is it access to care or is it access to health? And if we ask, what are the barriers to health, we get a laundry list. And I'm going to pause on this one for a little bit so you can digest it. Because there's something here that everybody in the room has probably witnessed as a barrier to health. And when you look at, don't worry, if you're taking pictures, you can have all of these slides for free. And there was a link, you probably missed it at the beginning, and there's another link at the end, and you can download them, and I won't charge you a penny. So this is the laundry list, and I'm sure I missed some. Is anybody using a social determinant screening tool? A couple. So the screening tools, and there are 4 or 5, and they're gaining in prominence. Some of the challenges that we're having with those screening tools are the same ones we had with the screening tools that we've been using in primary care. The answers aren't necessarily codified. The EHRs don't know how to understand them, and therefore, if we don't have a way to represent that knowledge, we can't carry it through to other systems. And I'll talk a little bit about why that's important. But each of these things is really important. And so the question is, where do we start? And how do we do that? I didn't realize I was going to be kicking the doctors in the shin so much today. But I did promise that we were going to think differently about how we solve problems, right? Because this is the Better Health Conference. It's not the Better Care Conference. And I think that's really important. Sometimes we talk about how we need more health and less care. More health and less care. We put ourselves out of business like the dentists did with fluoride in the 1970s. We would be in great shape. So the way physicians think about it, this is screening, and this is what we think about when there's screening, right? Raise your hand if you've been told by a physician or other clinician that you need to come in for your physical. Your physical. Any doctors in the room? Dr. Agresta, pleasure to see you. Is there any evidence for an annual physical that this is an important part of the service we provide to our patients? No evidence whatsoever for the folks in the back who couldn't hear Dr. Agresta. This is not evidence-based medicine. So why is it that we tell our patients to come in? And I'll share too much information about my family now. My wife takes a medicine for her eyes, little eye drops. She has dry eye syndrome. She's married to a doctor. She doesn't go to her doctor very often. She's a healthy 53-year-old. And she called her doctor's office for a refill for her eye medicine. And what did they say? You have to come in for your physical. And I was like, honey, do you want me to call your doctor? Because, of course, you know, doctors call doctors. And she said, no, I'm just going to be a regular patient and I'm going to do what they tell me to do. And I said, okay, you go do that, honey. 3 weeks later, of course, she didn't see the doctor. She saw the PA because the doctor's booked for 6 months, and we'll talk about that maybe someday. Why is the doctor booked for 6 months? Because of this. So she sees the PA. 4 or 5 days later, you know, she got the refill. It's fine. And she got, you know, poked and prodded in places that she didn't need to be poked and prodded. And then I brought the mail in one day, and there's this thick envelope from the practice. What was in the thick envelope? She didn't get into college. EOB, that was from the insurance company. That came later, because we have a high deductible health plan. No, it was her lab test results. Mailed on paper, and there was a laundry list of lab tests none of which was indicated. Why did they do that? Oh, and a urinalysis. Dr. Agresta. For those in the back who couldn't see, he did a Homer Simpson, right? There's no evidence for this. The practice generated roughly $350 of lab revenue. The insurance company paid it because it was coded as screening. This is my N of 1 research study. This happens every day. I gave a talk at a conference of health insurance companies a couple of weeks ago, and I said, do you know this is happening every day? And they all looked at the floor. They know it's happening every day. This is the least of their problems. So this picture is what we think of as screening. And we've been taught to screen, and there are attributes of screening. There are things that we should do for screening. So screening tests have to be cheap, right? So the urinalysis, great example, unintentional. It's a cheap test. It tests for common stuff. So what's common in a 53-year-old healthy person? Nothing. So that's why that test wasn't indicated, right? There is no disease for which they were screening. And it's stuff we can do something about. So if my wife had, I don't know, renal cell carcinoma, perhaps it would have been picked up as red blood cells in her urine, which would have caused a, what's the word for waterfall in Spanish? Cascada, right? A cascade of events that would have cost lots of money, and perhaps we would have found my wife's renal cell carcinoma. So screening tests need to be all of these things. And we physicians have been trained to screen for things that are, screen in a way that's inexpensive, screen for common things, and screen for stuff we can do something about. Now, our poster child for the day, Dr. Agresta. If a patient came to you and you administered a screening test, and the screening test was positive for 4 of these things, what is the action that you would take in your practice to intervene so that the product of the screening test was acted upon appropriately? Would you know what to do?
Yeah, sure, but I've got social workers and behavioral.
Dr. Agresta has social workers and behavioral health workers. Of course, he works in the nirvana of primary care, which is not Schenectady, New York, or perhaps even urban Hartford, Connecticut. So in most cases, primary care doctors look at this, and nurse practitioners, physician assistants, clinicians in primary care settings. And I didn't mention cardiologists or, renal surgeons. If we screen for these things, we don't know what to do. We can't act on the social factors. And therefore, we just don't know what to do, right? I'm a doctor, not a fill in the blank, he told Captain Kirk. So the answer, and now we're getting to the answer of the title of the talk, right? The answer is we have to have something there first, right? We have to address the social challenges first. So before we start looking for problems, we have to have the way to solve it. Because until we have the way to solve it, screening for it is just going to cause all kinds of consternation. And so if we address the social issues, so Dr. Agresta talked about he has a social worker and he has behavioral health providers in his practice or accessible to him. And so this infrastructure needs to be in a community. And so the first thing we need to do is we need to prioritize, and I can't remember, the last time I was here I might have burdened this group. Raise your hand if you were subjected to my talk, what was it, 4 years ago? The 2 characters in the front and that guy. So maybe you've seen this and maybe you haven't. I love this. I use it every day. And if you're a physics expert, you probably didn't learn this in physics class. Priority equals value over work. Priority equals value over work. So how hard is it to do something is the work part. And we can measure work in hours of people time. We can measure it in dollars. It doesn't really matter. You don't have to do the difficult math on this equation. You just do the gestalt. And value, you can rate it on a scale of 1 to 10, 1 to 100, whatever. And if you do it the same way for everything, and now we're going to go back to our list, You say, huh, well, let's see. If we were going to screen for stress, what's the value of screening for stress? And we'll get to some interesting research on this one. Stress is a contributor to many things: hypertension, cardiovascular disease. Stress can cause depression. Stress can cause obesity, which then causes type 2 diabetes. So there's a whole, what's the new word of the day? Cascade of events that happen maybe as a byproduct of stress. So value really high. Let's give it a 75 out of 100. Work. How are we going to fix stress? Well, gosh, that might be really hard. That might be, on a scale of 1 to 100, 10,000. Because I'm not necessarily going to solve the world's problems, and I might not be able to address stress writ large. So the priority for stress might not be so high. Let's pick another one: transportation. Oh, there's a little community in Capital District of New York that just invested in $10 a ride to send people to wherever they want to go. So work there is low, right? And the value might not be 75, but we might sometimes do the right thing for people. So what we did in our community was we prioritized. So this is our community. And we looked at the needs of our community, and we asked people what were their problems? What were the things that they were struggling with? And of course, when you ask people what they need, sometimes they tell you what they want. What's the Henry Ford quote? Give people, if I'd given my customers what they asked for, it would have been a, come on, you know this one, faster horse. If I'd given my customers what they'd asked for, it would have been a faster horse, Henry Ford. So we didn't necessarily just give them what they asked for, but we listened to what they said. We also reached out to the community-based organizations, the food pantries, the homeless shelters, the soup kitchens, and we said, oh, what are the people who are coming to you? What are the problems that they have? And how can we help you help them most creatively? And so we prioritized. And the things that we picked were these: food, housing, I'll describe the respite program, transportation, which I've already described, and a SERPA program. Is there anybody involved in a SERPA program here? I'll describe what that is too then. So for food, 43,000 meals in our region, in the Capital District of New York, are provided by our food pantries every month. 43,000 meals. And so food insecurity is this problem that is not discussed, and people won't volunteer that they have food insecurity unless you ask them, and they are very ashamed about this problem. And so we've tried to make it easy for folks to get access to food assistance, and we will even do the Uber get you the food and bring it to you. We created a food pharmacy, which is spelled F-A-R-M-A-C-Y, for people who've just been discharged from the hospital, because guess what? If you've been in the hospital for 3 weeks, what's the condition of your refrigerator? And it's worse than my mom's. It's not good. And so what the food pharmacy does is it sets you up with 3 to 5 days worth of food. And then maybe Meals on Wheels can come. We can get a health homemade to help you get rid of all the moldy bread, etc. And so the respite program is a wonderful program that we think has also saved a lot of people, and it's saved a lot of money. One of the homeless shelters was refusing to admit people who were recently discharged from the hospital. Why was that? Because they were too sick. They don't have any healthcare providers in the homeless shelter. And so if people have health needs, they can't be admitted to the homeless shelter. But wait, the hospital just discharged them. So where do they go? They go to the street because they can't go to the homeless shelter. And then what happens, because they're not 100% better, right back to the emergency room within a day. And so there was this revolving door of activity of people who are being discharged from the hospital to the street, refused by the homeless shelters, and then back into the hospital because they had gotten worse again. And so what the respite does is the respite takes people who are well enough to not be in the hospital, and the hospital likes this because what does it do? Any hospital people? Reduces bed days because they've already been paid for the DRG, and so they want to free up that bed for somebody who's new and sicker, and so get them out of the hospital. We put them into the respite, and the respite is sort of a halfway between hospital and homeless shelter. We were able to rent a floor of a recently closed hospital. So this is a good thing, right? We're consolidating hospital beds in the community. So we rented a floor. We hired some caseworkers and one RN. And so the RN is there to make sure that people take their medicines, and she monitors their medical conditions. They're there for somewhere between 3 and 50 days. And that was something we learned. And so we talk about experimentation. Our first pass at this, we said, oh, sure, this is a great program. We'll give you lots of money. Why don't you do it? Keep people out of the hospital. And they brought people in, and their average length of stay at that point was 65 days. So for the first 6 months, the average length of stay was 65 days, which meant that their volume, by the way, they only had 9 beds, their volume was very low. So I went to the executive director at the end of this 6 months, and I said, we're going to have to pull your funding. And she said, oh, no, this is so wonderful. It's such a wonderful program. You love us. We love our people. And I said, yeah, but no margin, no mission. Like, you're not showing the value. Remember, priority was value over work. The work was the dollars that we were putting into this. The value was too small because the number of people served were too small. So this is sort of the second thing that we've learned about working with social care providers. Sometimes people call them community-based organizations. The social care providers generally have been funded by grants or foundations. Raise your hand if you're from one of these organizations in here. Do we have many? No, but you work. We have 1 representative. 2. Excellent. So tell me if I'm full of crap, and I'm open to it. You've not been measured on your productivity. There's been no quality measure necessarily of how well you're doing because you've gotten grant funding or you've gotten funding from the state or philanthropy. Are you nodding? Yes, you're both nodding, so at least an N of 2, I'm not full of crap, or at least not on this topic. And it's a good thing my children aren't here. So what we found is that this is very consistent. Now, I'll pick on Tim again. Tim's organization's focused on helping medical practices deliver high quality, highly efficient care. And yet the social care providers have never been thinking about this before. So another piece of what we've learned is that we have to teach them about things like throughput. And so an average length of stay of 65 days means that they can't serve the number of people who are necessary in order for us to make a really good business case for this program. Because remember, this is just an experiment. I'm experimenting with projects so that we can learn from them. And if we learn from them and we ultimately save money and provide better health for the community, then we're doing good things and we can ultimately pass the baton on to whoever's going to pay for it long term. I saw Cigna's here. Any other health plans here? We are in Hartford, Connecticut. Steve's here. So we've gotten the interest of many of our regional health plans in this domain, in each of these domains. So that 2 of the health plans are participating in our transportation program. Their care managers are enthusiastically using Lyft and Uber. And the CERPA program is Certified Recovery Peer Advocates. These are folks who have been through recovery and are assisting folks who are beginning their journey toward recovery, primarily focused on opioid addiction. And the folks who have traveled that road before are much better at helping new entrants into this journey than people who've never experienced it before. And so by certifying these folks, there's a 2-week training program that we put them through. They're actually certified by the state. And it's a very inexpensive way. We've trained 100 people to do this, and then they're out in the community. Many of them are volunteers, some of whom we pay. because they're part of the substance use disorder treatment organizations, and we can therefore prevent folks from relapsing, and we're having very good outcomes from that. So these are the things that we picked. What's key is that what you pick in your community might be different, because value and work, you might have different resources, you might have less or more money for something. So if we go back to our laundry list, right? There might be other things on this slide that might be more important for your organizations to focus on. So that's number one. There are three. Number one is prioritize. Number two is connect. And in order to connect in our community, we picked a solution. There are a couple of solutions like this, and this isn't necessarily a product pitch. We picked a product called Unite Us. Unite Us is a closed-loop referral platform, and enables all of these providers to make we leverage the language of clinical decision support in the clinical domain. We want to make the right thing to do the easy thing to do. So if we imagine Dr. Agresta's in his office, and now he has a suite of services from which he can choose to address the social needs that he's just screened his patient for. And now he says he goes into the Unite Us closed loop referral platform, and he doesn't have to say, I know the food pantry that's near your house, or I know the substance use disorder treatment facility that you could go to. He doesn't have to memorize all of the social services in the community. He logs into Unite Us, or his referral coordinator logs into Unite Us, and he says, needs food assistance. And that's it. All he has to do is say, need food assistance. Now, at the same time, the food pantry, if there's somebody down there coughing, what's their current model of how they get that patient treatment? It's a 3-number thing to dial. And it's not 411. Close, it's 911. Somebody down here said 211. 211 would be great. By and large, it's 911. And what we are doing with this platform is we're implementing 211. If you don't know what 211 is, in many communities, 211 is sort of the referral center for a community. So we're working with 211. They actually staff the back end of our Unite Us framework. So you can call it, or you can use the computer, but what we're doing is we're saying it doesn't matter that you don't know where this patient can get services, or this client, or this member, or this person, or this human. All you need to know is that they need services, and we'll take it from there, and we won't let them fall through the cracks. And that's what's most important, is the confidence that somebody's not going to fall through the cracks. And so in order to do that, we call our 211 folks air traffic controllers. So they're watching all the time. And so we have a dashboard, and we can see somebody was referred for food assistance, and at 48 hours, they turn red, because we've been unable to get them to food assistance for some reason. And if that reason is their cell phone doesn't work because they ran out of minutes, or we couldn't find them, they weren't on the street corner where we expected them to be, we send out our community health workers, and they go find them. So we're committed to not letting folks fall through the cracks. Once this infrastructure was set up, so we set all of this up, and then we started screening. And this is the only part where we're going to talk about health information technology. So when we screen, we acquire data. And I talked a little bit ago about the need to acquire data in a systematic way. Because if we, just like we type in HYPERTENSION into an electronic health record, and it's just that word, it's really hard for us to carry that information from one electronic health record to another, if it's the word. What's a 3-letter word for hypertension? HTN, somebody said HBP. You could make up all kinds of things, and guess what? Doctors have, right? There are 40 or 50 ways to describe the same problems, and that's why we now have SNOMED CT and other standardized nomenclature that explicitly expresses a semantic concept. There's work going on nationally to describe the social needs. There are ICD-10 codes now being created. There's some SNOMED-CT concepts being created, and that's all in process. But we're not finished yet. So there is still some mapping that needs to happen in this domain. But the first step is acquire. And it's just like we're acquiring information about hypertension or someone's allergies or someone's problem list. We have to acquire this information. For us, it's in Unite Us. We're not expecting the physicians or nurse practitioners or physician assistants, the clinical community, we're not looking for them to acquire this information. We're acquiring this information in the social care community to start. After we acquire the information, we aggregate it. We have a health information exchange in our community. There are 8 of them in New York State. Is there one this week in Connecticut?
We'll hear about it later today.
Oh, we'll hear about it later. I got a this from Dr. Agresta. I guess he'll be talking about that later and teaching us about it. Connecticut's in a unique position of what's the metaphor? You know, in Africa, they didn't connect all the little villages together with telephone wires because cellular, right? So good thing Connecticut is taking advantage of its lack of investment in health information exchanges, or maybe not lack of investment, lack of completion of project. So it's a good thing. Let's make lemonade out of that. So we pull the information together, we aggregate it, and then we say, well, what's interesting here? What's important? And that's what we call analytics or software products that are, you know, charging us millions of dollars to analyze. But it's really just asking a question of a data set. So our air traffic controllers are looking at the product of our analytics solution. And right now, our analytics solution is 2, software engineers who make the dashboard. And it's very simple. This is not rocket science. The most important part is we act. And so this is the virtuous circle of the 4 A's. Sometimes I draw this with another A in the middle, which is accountability. We all need to be accountable to doing the work of following the 4 A's. Because if we don't act, then we're going to lose the ambition to acquire. And the whole thing will stop going around in circles. So some examples of other communities that have done interesting things with the 4 A's. So this is Linkages. Linkages is a project in Palo Alto, California. And this is where primary care doctors have recognized a social challenge that members of their community have encountered, which is isolation. So they screen for isolation in the aging population, and when there's a positive screen for isolation, the action, so acquire the information that isolation exists, aggregate that. They had to do that to start to make sure that there was a problem that was big enough for them to solve, right? Analyze it. Looks like isolation and mortality are connected to each other. This is important. That's the V over W, right? So V means it's important. Now, how do we make W small? How do we make this very little work for the healthcare provider? Well, we're going to make it easy for them to write a prescription for something. And they created the solution. So the prescription here is Linkages, link ages. So they take, it's like a dating service for old people and young people, but they're not romantically engaged. They're engaged on things of common interest. So here's an example. There's a request, looking for some assistance writing a letter in French to my family in France. And there's Danielle, she looks young, and she's asking an old person who might speak French. So we're linking young people with needs and ambitions, and sometimes these are community college students who are studying something like accounting, and maybe there's a retired accountant, and we're connecting people to each other. And just this program, if you look at the intervention group versus the control group, reduced hospitalizations, reduced morbidity, reduced mortality. Single-digit percentages, but it's still real. It's tangible, and therefore it's paid for itself. One example. This is Maya. I can almost read her name tag. This is our food pharmacy in Schenectady, New York. And I described it earlier, so I won't be redundant. You can tell she's super happy. The first week we had 15 people use it. The second week, 45. We're now serving about 60, 70 people a week through this food pharmacy. So when we see these sorts of services used so much, we know that there was a need for them. And so she's happy, we're happy. Looks like they need some more healthy food there, and the bananas look kind of rotten, but it's better than nothing. This is Sister Mavis. See, she's the lady in the middle. And this was the opening of our respite program. And it's named after Sister Mavis. It was her idea. She's 92. She's one of these Irish nuns who is a bit of a potty mouth. And she was so persistent in getting us to pay for this program. So I wanted to put her up because she's really the star of the show. The hospital executives and all that, they're all, pretending to think it's a good idea also. Here's another interesting example of what happens in a community that we hadn't quite thought about. So it's a social intervention that improves the health of a population. And this was fairly recent. I like to put reasonably recent things in. So this is June 2019, school bus emissions, student health, and academic performance. If the school buses have a filter on their exhaust, the kids are smarter. That's my short summary of this paper. Hard to believe, but there was significant findings. And how, P equals V over W, right? So how expensive is it to put a filter on the school bus exhaust pipes, right? And what's the value of smarter kids, right? Why wouldn't we do something like this? Social factor, social intervention improves the health of a population. And this is from just this week, hot off the presses. It's a really good thing I didn't do the slides till last night at 2 a.m. Having a purpose in life helps you live longer. Having a purpose in life helps you live longer. Here's the conclusion. This study's results indicated that stronger purpose in life was associated with decreased mortality. Purposeful living may have health benefits. Future research should focus on evaluating the association of life purpose interventions with health outcomes, including mortality. In addition, understanding of potential biological mechanisms through which life purpose may influence health outcomes would be valuable. It was written by physicians. It's actually a really interesting paper, and they talk about what some of the potential biochemical mechanisms may be. But doesn't it make sense? And if you think about your own life and the people around you, I've seen some old friends today, and invariably people say, "So how you doing?" And I say with integrity, "I'm doing great." Part of why I'm doing great is because I'm doing stuff that I really love, and I'm serving others, and I'm helping communities be more healthy. And so, based on this study, I'll live a really long time, and I'll be like Sister Mavis and live to 92, and I'll probably have a potty mouth too. So people who have a sense of purpose are more healthy. Sigmund Freud said to love and to work. This is what we strive to do. The guy in the upper left is my grandpa. He was a psychiatrist. The guy in the lower left is my dad. He was a psychiatrist. And as they say, the apple doesn't fall far from the tree. What my dad often used to say to me is that he helps people be successful. Helps people be successful. And there's my nerd daughter with her nerd dad, having just graduated from social work school. She didn't fall too far from that tree either. And it's such a pleasure. And I do feel a sense of purpose in being part of a line of humans who are serving others and who are doing the right things for others. We're getting close to the finish line here. And I do want to have some time for tomato throwing, question asking, and whatever else you'd like to offer. A key part of what I learned as a family doctor, and I have recently learned, my daughter learned as a social worker, and perhaps my dad and his dad learned as psychiatrists, was that we have to create pull. And in our organization, Alliance for Better Health, this is a concept that now our whole team understands. And so when I say create pull, they get it. And perhaps in addition to cascade, this is something that you can take home because it's so important and it's a guiding principle behind everything that we do. What we mean when we say create pull is that we meet people where they are. And here's book plug number 2 of 2. Anybody here been trained in motivational interviewing? All right, wow, 11%. So motivational interviewing teaches us that we can't tell people who to be. We have to ask them who they seek to be. At one of the conferences I was at yesterday, it was a conference on food security, and one of the speakers talked about how people would rather starve than be treated inappropriately, be insulted, be told what to do or who to be. So she was talking about how is it that we can make the management of food insecurity and how we can open the doors in a non-judgmental way. Motivational interviewing is about doing that. It's about understanding and really listening to what people and communities and organizations need and want for themselves. And remember earlier I talked about the doctors and the hospitals, and I was joking a little bit and picking on them a little bit, but an important part of what we do, I wasn't going to show that one yet, an important part of what we do with those organizations is that we don't judge them. We don't judge the hospital for being fee-for-service and needing that revenue from the emergency department because this is where they live. This is their life experience, not unlike the heroin addict who has been addicted to heroin. And until the hospital says, I don't want to be addicted to fee-for-service, they're not going to change. And we can't scold them into changing, just like we can't scold the heroin addict into changing. We have to ask the heroin addict, do you want to change? And when they're ready, and they ask us to change, ask us for help, that's the creation of pull. And so a good friend of mine is a psychoanalyst, and she says what she does with her patients is she asks them questions to put them off balance a little bit. A question one might ask a smoking teenager is, do you have any difficulty getting dates because you smell like an ashtray? That might be a little bit more confrontational than we need, but it makes the point, right? Because a positive answer there can then lead to a request for assistance for help. And that's the core of motivational interviewing. And so we use these techniques not just with people, but with organizations. We ask them where they want to be, and that's what this slide is about. It's about where do you want to be, and how can I help you get there from here? And so here's the link to the slides. I think we have about 4 minutes and 83 seconds or 63 seconds. If folks have questions or suggestions, so it's mdlk.us, CTBH19, Connecticut Better Health 19.
You have a microphone in the back.
Microphone in the back. Over here, and the microphone's not going to get to you in time. A couple.
Dr. Reider, thank you so much. I did see you 4 years ago. This was a great presentation and very timely because everyone I know is talking about SDOH and new codes and so on. But I wanted to ask you, since you have this community sense and this wonderful feel for us as patients and caregivers and so on, what we can do in healthcare to help our friends and family who are facing some of these obstacles that we see happening either in the healthcare or in their own social life, like finances and transportation and so on. What should we be saying and doing?
An easy question. My first answer is I have no idea. My second answer is maybe we should just do the stuff that we've been talking about here today, right? So what is it that they seek to find or be, or do they need an advocate to help them? And I think in at least in my life, and as I witness my friends' lives, we're a bit of the sandwich generation. Those of us, without hair or perhaps with decades behind us. Our parents are getting older. Our kids have perhaps escaped high school and perhaps even college. And we know people who have enhanced health or social services needs. In my family, there are members of our family with behavioral health challenges. So how are we there for them, navigating the difficult, maybe needle to thread between enablement and empowerment, right? So aside from understanding where someone wants to be, finding the resources, perhaps through primary care or through social service agencies. In our community, we do have 211, which really is a phone number, and often they can help. So it's about advocating without enabling, empowering without judgment, and maybe that's the core, is that it's so easy to judge, and it's so easy to put ourselves in someone's shoes, and really hard for us to understand where they really are. One more over there. And I can't see everybody because there's super bright lights. There was a song about that.
Thank you very much. I wanted to talk about that P is equal to V by W. Now, I'm a psychiatrist. I'm a company that goes and does home treatment with 3 teams of people. Now, I would have looked at the value slightly differently. In the 65 days, or 35 days, whatever the person was in the respite, I would look at how many times did they not go to the ER, and in those 35 days, what did my team do with him to start him off on medication and observe him using PHQ-9, whatever it is. So there are ways in which we can increase the V while they're, if you know Jeffrey Brenner, 15% of the superutilizers used up 80% and 20% used up 90%. If some of those people staying for 35 days, 40 days were among the 15 or 20, we have done our value.
Absolutely. So I violently agree with you. This is a tool that can be used to assess the value of an intervention, right? And we always have to remember, so often people will say, I'm prioritizing. But what they're actually doing there is they're assessing value. And the key to using this tool is to understand that we also have to think about the work. How much money are we spending? How much time are we spending? And so on. So there are lots of inputs to value. We can make it very complicated. I like to start with simple because I'm not very smart. One more.
Hi, how are you?
I'm great, thank you.
Great. I was wondering if you could talk a little bit more about the IT solution that you've implemented in your community and the platform. What are some of the features that have worked the best, and what are some of the challenges you've had to implementing that platform?
So, I love this story. When I started, I thought, well, what we really need is a care management platform. And so we took a little survey of the community, and we said, look, if we could all share one care management platform, then we could share the care management activities across the community. And this is where I relearned the principles of disruptive innovation. Because the hospitals already have care management platforms, and the insurance companies already have care management platforms. And in New York, we have these things called health homes, which are funded by the state. They had care management platforms. So the first thing, our first idea, push, not pull, mistake, right? But this is how we learn. We make mistakes, step in piles of dog poo. The first mistake was we decided what the community needed. And the community said, no, we've got that. And so we went beneath that and said, well, do you have a tool that you can use across entities to refer patients to each other. And there was silence. And so what the platform does for us is just referrals. Because a core criterion here was that we weren't replacing something else. We were adding something that was simpler, very simple, and no one felt threatened by it. And I think that was the key criterion for what we implemented. It's the technical functionality of this tool is quite limited. It's just referral management, and we make a directory. So similar products are directories of community service. We filled up the directory, and then we connected them all each other. So right now we have 53 organizations that are all sharing this referral management system. So somebody's at the food pantry, they need to have housing assistance, we use the platform. Housing assistance needs food, use the platform. Housing assistance needs transportation, use the platform. But as soon as you get into care management, we're outside the scope of our activity. So I think we're at time. I'm almost getting nudged about that. This has been wonderful to be here. Thank you so much. And remember to have purpose. Thank you.